I'm joined as ever by my friend Richard. Hello, Richard.
And your smiling face. People can't see it on radio, but I can, and I'm very happy. It cheers me up.
That's fine. I've been told I have a face of radio, and I don't care.
Well, whether or not that's true, I'm seeing it I'm seeing it live, and I'm I'm happy.
Good, jolly good. Now we chat pretty much every week about stuff in the news, particularly in the news, really about medicine, one way or another. Because in a former life, you were a GP because you've retired now.
I met a guy just walking the dog this afternoon, and he said, "Have you retired?" And I almost said to him, "Well, yeah, that's why I'm walking the dog at 4:00 in the afternoon." I didn't. I said, "Yes, graciously, yes, yeah, thank you. I have retired." And I ran into this woman just outside a news agency the other day. "Wow, have you retired?" She was a bit crosser. I said, "Well, yeah, I have actually." "You can't do that." "Oh, you know where the conversation's going. There's not enough doctors around." I say, "Well, that's very kind of you, but." The magic age of 65, and there's other things I want to do, including this radio program. So yeah, I'm afraid you'll have to seek help elsewhere.
It's really funny. There was a doctor we used to go to. Dr. Lisa was her name. She was brilliant doctor, and she retired very early. I think she's like 40s, and she went on to something completely different. And everybody came into the practice. What? But what do you mean she's gone? She's not old enough to retire. She's got to be here. She was very popular.
I know.
Anyway,
it's kind of people to say so.
No, it's better than the other one. I'm glad you've retired.
Thank goodness. We were hoping you went 10 years ago.
Yeah. No, that wouldn't be quite so good, would it? Right. Now, have you got a topic for us for this session?
Yes, and as you mentioned medicine, I was just looking back through, because we don't always talk medicine, but recently we've looked at AI and medicine. And then we had a wonderful question from one of your listeners a couple of weeks ago. Are there some brain changes in the mother that enable her to bond better with her baby? And I said at the time, in the typical medical speak, don't know. So I'll look it up. So I did. And it was particularly relevant because my youngest daughter is now 2 weeks postpartum today, in fact. She had little Boaz 2 weeks ago. And so I did this last week as the main thing that we talked about. And I threw in a little thing, which I knew I wouldn't get away with on the show, which is, one of the papers that I've read says that the father's brain, there's paternal brain changes as well. So clearly Andy said, well, like what? And I said, well, actually, I don't know. Okay, I'll look it up. So what I thought I'd do very briefly, because we won't spend the whole program on this week, but I'll just have a little look at what happens in the dad's brain that's been written about before looking at the main thing, which is prostate cancer screening, which is massively in the news at the moment. So,
I am glad before you started, because the person that sent that question said, but I don't understand. How does the dad's brain change? That makes no sense. I'm so glad you're covering it.
Well, unless we've got a creator who knows that the dad's brain needs to change as well. Anyway, this is what I found. So if you remember last week, the mother's grey cells, that's her brain cells, neurons, decrease. That's consistently found in papers. And it decreased, the grey cells, the grey matter, decreases uniformly throughout the mother's brain. Interestingly, the father's grey matter, so that the neurons react somewhat differently. It increases in some areas and decreases in others. So, for example, the grey cells increase in areas linked to motivation and nurturing, the hypothalamus, the amygdala, part of the prefrontal cortex, that's intention, whilst decreasing in areas interestingly linked to emotional ups and downs. So hopefully fathers get a little bit less up and down when they need to be a bit more stable to perhaps cope with the mother and the baby. It's a further pointer, I think, to neuroplasticity, which is the brain's ability to change and adapt. And essentially in the dad, what changes, motivation, nurturing, it's prioritizing the infant's safety, more vigilance, more risk detection, less emotional lability. So I'm not going to go into further detail, A, because there's not as much information for dads, and B, we looked at it last week. But yes, amazingly, there is neuroplasticity in dad's brains as well as mum's. And I can only conclude, bullet point, that I guess God knew what he was doing.
Well, yes, I would concur with that. It doesn't surprise me that the mum's brain would change around having a baby. We understand there's hormones, there's all this stuff going on to create the potential for creating a baby in the womb. And that makes sense. So, okay, there's going to be changes in the body. They're going to get a larger stomach, sort of, and things are going to change. But it was the dad thing that I thought, Well, I can't believe that, but also that actually makes a lot of sense because mums and dads are both required to make a child, one husband and a wife, a man, a father and a mother. That's what you need to make a baby. So if God did it that way, it makes sense to me as much as it doesn't. It makes sense that the mum would change in the brain and the dad too.
Well, I think what we found with the mums is that they found the changes and then discovered later how and why they'd happened. Maternal hormones essentially acting on, um, you know, uh, sensory elements within the brain that respond to the hormones. At the moment, we know with the dads there are some changes. Quite why? Because obviously dad's hormones aren't going to change anything like as much as the mums. So we don't quite know why. But as you say, the fact is there seem to be changes. And yeah, that's how God's designed us. Our brains are more plastic than we thought, certainly than when I was a medical student. Brains were thought to be fixed. Oh my goodness. What a big change over the last 40 years.
I mean, that's medical, that's medicine and science. It never stands still, or it shouldn't do, as it discovers new things. I mean, various drugs that we used, there's newer drugs or better drugs or whatever, and it's going to change. Even things like the recovery position. I remember when I first learned the recovery position to when I learned it 20 years later, it's basically the same idea, but it's not the same.
No. And things develop, and that's why when people say, "Oh, science has all the answers," obviously it doesn't, because it's changed over the years. Science is important, but it does not have all the answers. But I think it's great because science sort of catches up as we begin to understand how God has made us and how He's designed us, and science catches up, and then you can put the two together very nicely.
Which I love. And Sherry often talks about, Sherry Seligson, who writes in our magazine, she often talks about how science is always catching up with the Bible already said, but scientists have suddenly thought, oh, the Bible said that first.
Ditto.
Yeah. Right. Where would you like to take us on for this evening then?
There's really been a big hot topic in the news, in the newspapers recently. Should men's commonest cancer, that's prostate cancer, be diagnosed more through actively looking for it? I.e., should men be universally screened, say over the age of 50 or even before? We're talking about PSA, the blood test looking at prostate cancer. Should they be actively screened? Should everybody be screened looking for more prostate cancer? And in many ways, the question, when I phrase it like that, seems like a no-brainer. And we have celebrities with prostate cancer, notably Sir Chris Hoy, the cyclist, sadly picked up when he was in stage 4 and terminal. He definitely thinks everyone should be screened. Rishi Sunak, ex-Prime Minister, has thrown in his two pennyworth here, even the King. And it's so, isn't it barn door obvious? Well, if you then add in, of course, the women's equivalent common cancer in terms of frequency is breast cancer, for which we've had screening for many years. It's the commonest female tumour. There's more than 50,000 breast cancers per year. It affects 1 in 7 women. Deaths 11,400 annually. So yes, women are screened between the ages of 50 and 71 every 3 years. But prostate cancer, which frankly is equivalently common, 55,000 men get prostate cancer diagnosis annually, 12,200 deaths, so fractionally more, is unscreened. If you're a black man, you have double the rate, although if you're an Asian man, your frequency is less. So some people are arguing not just for screening every 3 years, but for every year, annual screening, add it into your annual blood check. But at present, prostate cancer is not screened at all. Isn't this both unfair and sexist, if you like, a form of male discrimination, if I'm going to be a bit emotive? So what I thought I would do, because there's been loads in the paper, and usually just from the point of view of, my goodness, this is terrible, we should be screening everybody. So I thought I'd compare the two cancers and see, is there any reason for treating them and screening them differently? So we'll start with breast cancer. Well, screening, what it does, of course, is to look for early signs of cancer when perhaps no lump has been noticed. I might say a very good friend of ours, particularly a friend of my wife's, absolutely had this. She had a routine mammogram about 2 years ago, no lump, found extensive cancer, for which she's undergoing treatment, and I'm pleased to say doing very well. But good job she had that mammogram. Probably without it, dare I say, she would not be doing so well now. So that was earlier treatment after an unexpectedly bad result. So she was very glad to be screened. Of course, early treatment is therefore less invasive. The results are better. And it's notable, for example, in breast cancer, that almost all sufferers diagnosed at the earliest stage live more than 5 years. And screening is estimated, I checked this one out, to save perhaps 1,300 lives per year in the UK. That, of course, is out of more than 50,000 tumours. So, are there any downsides to screening for breast cancer? Well, yes, there are some false negatives. And a false negative is where the tumour is missed. It should be positive and it's not. It's missed. There are also some false positives where a tumour is diagnosed when it's actually not there. And the risk, of course, with breast screening is you turn up some tumours which are then treated unnecessarily. In other words, you've got a tumour, but it's not going to do you any great harm. As a doctor, we used to see this in the very elderly come with a small lump, say someone of 80 years old. You might give them a bit of tamoxifen, or you might not with advice, because it's just going to make no difference to their life. It's probably been growing slowly for 10 years and it's not affecting their lives. And of course, excessive treatment, if you turn up tumours and think, oh my goodness, I'm obliged to treat, then you can talk about surgery, hormones, chemotherapy, radiotherapy. And these may well be excessive responses to a minor issue. Not all breast cancers are bad. And the problem that we face at the moment is that doctors do not know which tumours are going to be nasty and which ones aren't. So, for example, a very tiny one, which is a ductal cancer in the breast ducts in the nipple, a ductal cancer in situ, it's just there and nowhere else. Some will progress and some won't, and we need to have more investigation, more research into which ones will turn nasty and which ones won't. But overall, I think there's no doubt that breast screening is useful, is helpful in locating early cancers. It's not perfect. The Google tells me that probably 4,000 women are overtreated per year, and that's the other side of the coin to 1,300 lives being saved. So that's 3 times as many are overtreated. Plus mammograms, of course, involve a tiny amount of radiation. So regular mammography every 3 years slightly increases your chance of breast cancer. But overall, I think the risks are worthwhile. And especially, of course, with those with a bad family history, it's a no-brainer. Or if you're known to have faulty genes, some people will even need an MRI scan at the age of 30 or 40. Oh my goodness, yeah, I remember a friend from medical school who sadly was in that category and died young, despite having a bilateral mastectomy. You know, when you've got bad genes, you absolutely go for it. But it's not perfect, breast screening, but overall, it's well worthwhile. Now, let's just hold that aside and we'll move on to prostate cancer. How does screening for prostate cancer compare with breast cancer? Is it favourable and therefore well worth doing or not? Now, I mentioned earlier that to enthusiasts, Sir Chris Hoy, Rishi Sunak, the King, it is a no-brainer and probably quite unreasonable that the country, if you like, doesn't invest in its men as it does in its women. But a recent article in the Times, and this is what really got me going on this subject, by the resident doctor, Mark Porter, who I met once when we were both a lot younger, who's a very reasonable guy. He was very honest and he says that he hasn't been screened. Now, he's a little younger than me, so I guess about 62, 63, and he is not screened for prostate cancer. He's not done a PSA. Well, I thought, that's interesting. I'm going to read this article. Tell me more, Mark. And his reasons about the pros and cons were very helpful. The pros, yes, of course, like in breast cancer, screening can detect more aggressive cancers where the PSA is suddenly sky high. So I remember as doctors, you do a PSA on someone, oh my goodness, it comes back in the hundreds or even thousands when it should be, say, less than 6. And you're thinking, oh my word, 100% this is going to be cancer, rapid access tomorrow. So very helpful for these people. So it allows for, again, more effective earlier treatment with reduced spread and reduced mortality, reduced death. Well worth having. Again, isn't that the case made? No is the answer, because the situation is much more complicated than for breast cancer, because prostate screening comes with major downsides. Firstly, I remember as a young medical student, as a young doctor, something that we were taught is that if you look at post-mortems of very elderly men, so over 80, you'll turn up undiagnosed prostate cancer in at least 80% of the over 80s. And by the time you get to over 90s, it'll be 100%. Everyone will have an element of prostate cancer in the extremely elderly. In other words, it's an incidental finding. They have not died from prostate cancer. And in a sense, it's no different from 100 people walking past my surgery window. And some of them will be walking around, adults will be walking around with undiagnosed gallstones, which haven't caused them any trouble. If they do, in they come to the surgery and we whip them out. But there's people walking around. You may have them, Andy. I may have them. I don't know, because they haven't caused any trouble. people you can be unaware of their existence. And the trouble, again, with locating these non-aggressive, slow-growing prostate cancers, a bit like with the mild breast cancers, is once you find them, you feel obliged to treat them. And you can do men, and I might add, their wives, a great deal of harm in doing so. Number one, anxiety. Simply knowing that you have cancer makes people anxious. Number two, physical side effects. Here's just three. Persistent incontinence from surgery, requiring pads or a permanent catheter. Erectile dysfunction. You see, the prostate lives at the base of the bladder in relation not only to the bladder sphincter, incontinence, but the pelvic nerves, erectile dysfunction. If either are affected, there's trouble. And another little-known issue, when you remove the prostate during intercourse, semen can go upwards into the bladder, which is painful, rather than downwards where it should go. Just a practical physical problem. That's known as retrograde ejaculation. Sorry for listeners to be a bit more, but this is the truth. and it's not only unhelpful, it's painful. So once prostate cancer is diagnosed, very important conversations need to take place between the doctor and the patient, outlining the benefits, but also the very real risks of treatment. This is why, again, people need to have all the information, and we need to do more research. Who really needs treatment and who doesn't? The people that don't, leave them alone. Otherwise, it's meddlesome. So we need, alongside this, of course, and this is the holy grail at the moment, a better test than PSA. And the researchers are spending a lot of money trying to find a better test than PSA, prostatic specific antigen for prostate cancer. So the reason, in short, for prostate screening being very different from breast cancer screening is unwanted side effects from overdiagnosis, false alarm leading to unnecessary treatment, serious side effects of treatment. And I might say PSA can be raised by all sorts of issues other than cancer. Prostatitis, inflammation of the prostate, instrumentation, having a catheter put in, even a GP's rectal examination will shove up your PSA because if you stimulate the prostate, it shoots PSA into the bloodstream. You do a blood test there and then up it goes. That's a false positive. So, the PSA is a blunt test. And at the moment, perhaps this will change in the future, we get a better test. But at the moment, there are very real reasons to be concerned about universal prostate screening. Now, that said, usually when people come in, they say, I've got some urinary symptoms. I'm struggling to pee, can't knock a wall down like I used to. I've got some incontinence, I've got some dribbling. 100%, all these people needed PSA done, along with a prostate ultrasound and anything else that we feel is necessary. So I'm talking with the prostate screening of people who are asymptomatic. They haven't got urinary symptoms. If you've got urinary symptoms, you hotfoot it to your GP and you'll get tested as you jolly well ought to be. But if you haven't got symptoms, it's perhaps something that should be discussed with your GP. Well, what are the pros and cons of screening? And any reasonable GP will at least have some of this information to their fingertips or get back to them if necessary. So whilst our celebrities have a very powerful voice, they're not always right. And they're thinking about it, dare I say, from a one-eyed angle. And while I feel very sorry for Sir Chris Hoy, and I understand his position, you don't want to you want to change systems on the behalf of, if you like, one bad prognosis. That's a bad reason to do so. There we go. Prostate screening. It's a complicated business.
Yeah, I have a few thoughts on this one. I'm on mess with my heart. One of the consequences of the meds, which I know is the meds, because if I've come off it for a few days, all the problems immediately disappear, is going to the loo takes a bit longer. Now, I don't panic about that. I know it's to do with the meds. If I come off the meds, the problem goes away. But that's just a med which can create a symptom, which is not. It's a side effect of something else. And of course, that's one of the problems. I've got a problem. I know I haven't. I'm not. It's not. But you might think you have and not think about, well, what else are you doing? And are you drinking enough and all the rest of it? And that's not a problem.
Too much caffeine and getting up several times at night. Well, it's not because of your prostate. It's because of your caffeine intake.
Exactly.
History.
Yeah, I tend to have a meds at night, so I have a glass of milk at night, which is cold because the meds dissolve too fast otherwise, and it's always cold milk, which is the best thing. So I'm now getting up in the middle of the night for the loo, which is annoying, and it's not an old man thing. It's I'm drinking a cold drink late at night. What a shock at 2 o'clock! I'm having to go to the loo, and again, it's a side effect of something that I could prevent. But if we're not careful, we see things and we start to put things together, and without medical knowledge, all of a sudden we're Google doctors. I've got this. I've got these problems. because we put two and two together and get 84 and a half.
Indeed, and it is a complicated issue, and I hope one day there will be universal prostate screening when we can tighten things down much better with a better test, and then having done so, this person needs treatment, this one doesn't, and then people can make the holy grail is an informed choice. And at the moment, just saying everybody should have screening, I'm afraid that's not an informed choice. That's not an informed advice. It can be harmful, and that's worth knowing.
Yeah, and I think it is one of the thing is that I don't know much about either of the things, but I do know about mammograms that it's basically effectively a picture, which is in itself not invasive. Forget the radiation for just a moment, which is obviously a small dose. It's not an invasive procedure, but anything you do that is invasive can cause a problem which you may not intend.
No, absolutely. And to be fair, urologists are excellent at this these days. So, if we do say someone says, look, I'm 45, my brother had prostate cancer at 50, would you do a test? I'd say on that basis, I will. And when we get the result, I will refer you to the urologist to decide what to do, whether or not it's raised in that situation, because you've got a brother who's developed the disease at a relatively young age, particularly if it was a bad. And obviously, the younger people get it. I had a friend, have a friend who developed prostate cancer at 39. That's very unusual. And often when you get cancer younger, often, not always, it's worse, which is why you have your very elderly dying with prostate cancer when it doesn't affect them. It's a case-by-case basis, but it needs to be discussed.
I think the other thing that was really fascinating is you were saying, they're spraying the fields today. I don't know what they've been doing in the fields, but my voice isn't right. Anyway, you were saying that in 90-year-olds at a post-mortem, or even like 80-year-olds, then it's almost like a 10 in 10, 1 in 1 person have it. That says an awful lot, not about the fact that it's not serious, clearly it is, but actually it's one of those, a lot of us have it and probably it's not as big a deal for the majority.
Yeah. Now, that said, more than 10,000 people, 12,200, I think, die from prostate cancer. It can be a very serious disease. I'm not poo-pooing that in any way. But, there's a lot of people who have prostate cancer where it's a very mild beast. Some of them are simply watched by the urologists, so-called watchful waiting. And if the PSA suddenly shoots up and it gets a bit more aggressive, right, you might need some treatment. So, even having prostate cancer doesn't necessarily mean you're going to be treated. But if there's a younger person, and particularly if it's an aggressive type of cancer, they'll throw everything at it to keep you alive, and rightly so. But universal screening, which is we're talking about here for asymptomatic people who don't have urinary issues, it's not as simple as with breasts.
And I think also, playing a little bit of a step back, breast screening costs money. If you're checking for the cancer in men, it's going to cost money, it's resources, and there's only so many resources are going around. You can't afford to do everything. We had this conversation, didn't we, about dementia. There's a test. You may have dementia or not. Should we test everybody? And one of the things I remember you saying very clearly was, well, yes, but what if it's wrong and you then spend 30 years not living your life because you're thinking, that's it, I'm going to get dementia, and you stop living your life because actually if you didn't know, you'd still be living.
Yeah. And even if it's right, it can affect some people very badly mentally. And personally, for me, I would choose not to have it done. Other people would say, no, I want to know, and get my affairs in order, or whatever. Okay. So it's an individual decision, but one needs to have that discussion. It needs to be an informed choice.
It does beg another perspective, though, as Christians, in that if you know what you're going to die of, you're going to want to do something about it. If you've got breast cancer in your family, if you've got prostate cancer in your family, okay, you're probably going to be more aware of it. But everybody who has a type of cancer is going to be suddenly saying, I've had this cancer, you need to get checked out. And we understand that, and it makes lots of sense. But as Christians, there's a different perspective that if we know where we're going when we're going to die, which we do, it's why we have peace about living, because we know what happens when we die, we're going to go to heaven. If that's the case, you don't need to get screened for anything ever, because that's a really stupid thought. But if you know where you're going when you're going to die, actually these things are easier, I guess, how I'm putting it. They're easier to hold in a healthy and righteous perspective.
And I think it as Christians, we shouldn't let any disease destroy us. And I've had bowel cancer, and I'm aware of that, but I stick it at the back of my mind. It's absolutely not going to dictate my day-to-day functions. I need to take some tablets to deal with the side effects, but that's life. It's a very minor point. I wouldn't let it dictate, because he who is in us is greater than he who is in the world, and we know that disease comes ultimately from the fall of man, and yet God's got a good plan for our lives, and he decides, of course, when we live and when we die. It's in his timing. It's not cancer's timing. It's not the devil's timing. Yes, we may have a disease and that may shorten our lives, but it's all ultimately in God's hands. And I think that's very comforting and wonderful to have.
I'm saying this next part as a man who's had heart surgery under 50, okay? And I'm not being flippant, but you can die tomorrow getting hit by a bus. And if you spend your life panicking and worrying and being anxious about this thing that you may have and that you actually might have, or even that you do know you have, if you're not careful, you stop living life to the full now because of what might happen tomorrow. And even if you're fully healthy, you can die tomorrow. This isn't macabre. It's not dark. It's real life. When I went in for heart surgery, as safe as it could be described to be, because it wasn't open heart surgery, there's still a risk. I had a vasectomy years ago. I was told about the risk of surgery. You can still die from it. It's a reality. It might be ultra rare, but you have to go in informed, and everything should be in measured responses. If we're not careful, especially as Christians, we can lose perspective on the ability to live today, and then things control us. Our friend Steve Legg, the amazing Steve Legg, laughing till the end, laughing with the nurses in his last day or two, as Becca shared with us as she talked about it all. He had a really good attitude towards it. He had cancer. It killed him. It didn't stop him living, though.
That's a very good point. That's really is a good point. And I can think of two older people, but only in their 70s, Christians who died following major surgery, heart surgery. But they knew where they were going. They were at peace. And of course, I wish they'd survived. And, sadly, they didn't. But it's a step on the journey as a Christian, isn't it? There's a lovely story from an 8-year-old boy who'd had cancer and died. And people said to him in advance of him dying, how do you feel about this? He says, well, to me, death is like a McDonald's on a motorway cafe. It's a step along the journey. And I thought, wow, that lad has got something that most adults don't have. What a thought. He ate and he was at peace because he knew he was going to meet Jesus. And, that was it. And I'm thinking, wow, I'm in awe.
Yeah. I mean, you've had cancer. I've had heart surgery. Neither of us, I can answer for you. You didn't want it. You didn't want to go through that journey. You would much prefer to avoid it. I'd much prefer not to have palpitations that are still vexing me after 6 years, and they still can't get it under control medication. But you know what? That's part of life. On my bad days, I don't do so well. On my good days, you probably wouldn't even notice. And you have to live life. But if you're not careful, then you get panicked. And I do get frustrated by celebrities. Yes, everyone needs to have this thing. Well, do we? Are you medically trained? Is that a balanced argument?
I think what they're doing, and I get it, they're using their voice, they're using they're a celebrity, so people are going to listen to what they say, which of course makes it all the more important that they get it right, and sadly they don't, in my view.
No, I agree, and especially something like prostate cancer, the fact that there's so much else damage that can be caused by something that you may never have a problem with. We're not minimizing the effects of cancer here. We know it can kill, it can cause tragedy and all sorts of things, which are really hard. But it's got to be measured against mammograms. Okay, a bit of radiation. I mean, how many x-rays is it you've got to have before it causes a problem?
Sure.
Many thousands. So yes, there's risk. And yes, there's false positives and false negatives. But I'm always cautious about things where, do you know what, a more measured response might be more appropriate, because yes, it kills people. But like you said, 90-year-olds, 100% of them have got it. Well, that does say something about the fact that while it can be bad, it's clearly not a good thing, maybe it's not as bad as we might allow the fear to make it to be.
Almost like a normal disease of aging.
Yeah.
But if it occurs much younger, it's out of control, then you may need to hit it hard.
There's a topic that might make a good conversation. Normal parts of aging that we try and stop.
Ooh.
When actually perhaps we just need to accept that life changes. I remember you said at one point.
Oh, dear me. You do my thinking for me.
I know, sorry. You talked about how there are, is it 3 ages where there's quite, not we get much worse, but there's 3 ages where there's quite significant physical changes. So is it 50 and 70, or I've forgotten what you said now, but there are ages when things change quite dramatically in the body.
Yeah.
Is that right? Did I remember that correctly?
got that from someone else, actually.
Did I?
But yeah, yes, I've talked about areas of the body that continue to grow throughout life. For example, men's ears,
Yeah.
and I might add, men's prostates. And there was a third one which I could never remember. It might be part of the nose, but certainly ears and prostates grow throughout life, which is why old men look like elephants sometimes.
Yes, with barbed wire hair that pops out of your ear for no reason overnight. Or is that just me? Right, Richard, thank you. That was really interesting. I think it's really important that we have a measured response to things. It's very easy to knee-jerk panic, and we've got to do this, we must do that. And maybe sometimes there's a cause for that. And prostate cancer is clearly terrible. It's a devastating disease, but it's also a disease that people can live with for a very long time without even knowing about it. And that does mean we should use caution before running down to the doctor and saying, I need a prostate exam. You've got to look at me now. Well, perhaps not, but talk to a medical professional who knows what they're talking about, and don't conflate side effects of a medicine with advanced aging is my advice.
And be aware what celebrities say, but don't just follow it slavishly.
Yes, celebrity doctors perhaps might have a better say. Celebrity other ways, perhaps not. Richard, thank you. If you've got any thoughts on this, then you can let us know, or you can ask Richard any questions you like about medical stuff in the news. Hello at pure247radio.org. Hello at pure247radio.org. And we will ask Richard anonymously always. Prostate cancer and breast cancer screening. Thank you.
You're welcome.